Care of the Aging Adult, Unit 4, Part 3. This is Martha Olson, Iowa Lakes Community College. In talking about management of pain and how we treat that, somatic versus visceral can be treated very differently. Somatic pain, sometimes your NSAIDs and your steroids help more with that localized pain. Visceral pain, which is more of a deep aching pain, can be best treated with some of our opioids or other medications that help with that. Neuropathic pain then is kind of a constant or intermittent pain that might resolve or have some effects with our anticonvulsants or tricyclic antidepressants. That would be things like your neuropathy, your diabetic neuropathy, or herpes zoster, the shingles. In treating pain with the elderly, remember that usually half of the dose is prescribed initially because of the decreases in kidney and liver function to metabolize and excrete that. So we want to make sure we don't overdose or cause a toxicity because we give them too high of a dose that their body can't handle. Tylenol is very well tolerated and often good for many of our musculoskeletal pain issues that they have. Opioids have a very short half-life. Agonists like morphine, oxycodone. We want to make sure that we are using those with care because of the respiratory depression issues that can happen. When we look at using pain and identifying pain, that pain log or diary can help us to know that when do they have their most pain intensity. Is it an all-day chronic, they wake up with it, or is it something that we can medicate differently because of when they have the pain? What is their response to the treatment? What are they willing to do? What kinds of things have they tried in the past? When we look at pronouncing death for our death and dying, remember it depends on the state law of where you live and the circumstances around that. Got a call one time. The daughter that lives in Des Moines wanted us to go and check on her father, who is our neighbor. Went over to the house. He was in his bed. He had died in his sleep. The circumstances for that are looked on very differently because this was a man that was not ill, had not been ill, but had a very unexpected death. So they called in the police, who called in the medical examiner to look at that. If you have somebody that's older and expected death and there's no situation or circumstances surrounding that, it will be maybe looked on a lot differently. When we look at pronouncing death, we think of what are the signs. When I start seeing mottling or that purplish discoloration to the knees and lower extremities, that's an early sign telling you that circulation in that person is changing. The Shane-Stokes respirations, where they have periods of apnea for 20 seconds and then they will start breathing again, can be another early sign telling you that their body is getting ready. It's tiring, it's wearing out, and there are times then that I will call a family and just say, I'm noticing changes with your mother. I wanted you to be aware of that in case you wanted to be here. Some of our patients on hospice in the hospital are there for what I think a long time. And families get worn out and they have jobs and other obligations and they can't be there 24/7. It's always hard when the family is relying on you to kind of let you know when things are changing, because sometimes we miss it. You go in the room to do regular routine cares and you find that they have expired. Know what nursing specific activities after a person dies you need to do. If it's a hospice patient, we oftentimes will remove the IV if they have one, take the Foley catheter out, leave the teeth in. If it's somebody that comes in and they've died and it's been very unexpected, you may have an autopsy scheduled and then they want you to leave all the IVs and Foley catheters and all of that. We usually cleanse the body so when the funeral home and the family comes to view that they're cleaned up, because with death, oftentimes the relaxation of the sphincters can cause incontinence of both urine and bowel, and so we want to make sure that that person is cleaned up. We usually put a clean gown on them to send them with the funeral home, and they do return those things to us. If in doubt, again, kind of ask the preference of the family, ask another nurse that maybe has worked with hospice and patients in that. And then sometimes there are different customs, different cultural things that a family might want done. With some of the Middle Eastern deaths, the family wants to bathe and wrap them in white cloths, put some special oils on the skin. So again, asking the family what their preference is. When we look at some of the cultural practices, are they going to be cremated? Are they going to have a burial? Are all things that need to be kind of thought about during that time. For the remaining spouse, there's many adjustments. If it's a man that has never cooked and cleaned, he may have a lot of adjustments going home to learn how to do all of those things. Making decisions. If it's a woman that the man paid the bills and took care of everything, she may have a lot of adjustments for financial things as well. It varies between men and women, and I think that's also a cultural thing as we look at some of the, my generation and how men now are able to do more things around the house, whereas the older generation, what I think of as older generation, they might be more dependent on each other in those very traditional roles. There can be a profound change sometimes with numerous transitions, and the person is not able to transition very easily, and sometimes you will see where the remaining spouse dies in a very short period of time after the death of their loved one. So we look at Objective 42, describes some of the effects of grief and mourning on the elderly. Sometimes men who are widowed will hide their grief, pay less attention to themselves, lose a lot of social contacts. They don't like to be that fifth wheel there, or that person going out with their friends when they don't have their spouse with them. They can sometimes have problems with their self-confidence. And then there's also the sexuality issue as well. It's a basic human need, and when that spouse is lost, sometimes there's a loss in many areas of the life. At higher risk, those with fewer family or social supports can have a more difficult time adjusting to the loss of their spouse. So as we wrap this up, here's the references, and this ends Unit 4. Thank you.